Hey guys, Dr. Carmen Bryant here with NursingSchool911.net, back with another video, and today's video is going to cover acute kidney injury. So we're just going to dive right in and start talking about the different causes. So you can have pre-renal causes, intra-renal causes, and post-renal causes of acute kidney injury. And with pre-renal, you're going to think of etiologies that decrease cardiac output, that decrease circulating blood volume, that just in general decrease renal perfusion. So with decreased cardiac output, mainly congestive heart failure, okay, with significant systolic dysfunction, very low ejection fraction that reduces renal perfusion. Blood volume being decreased, just overall blood volume, so losses like from a lot of vomiting, diarrhea, insensible losses from sweating, hemorrhaging, hypovolemic shock. Anything that reduces blood volume is going to reduce renal perfusion. And then I have hepatorenal syndrome here out as the last listed cause, and hepatorenal syndrome is something that we see very commonly in our end-stage liver disease patients. And what happens with these patients is that the urea and other toxins build up within the body because of the severe liver damage, causing splanchnic vasodilation. Well, then in turn, that causes a compensatory renal vasoconstriction, which reduces renal blood flow and renal perfusion, okay, leading to reduced renal perfusion and pre-renal AKI, or acute kidney injury. All right, so that is pre-renal causes. Intra-renal causes, so there's a few more of these. The main cause of intra-renal AKI is something called acute tubular necrosis, and that's what it sounds like, right? So it's necrosis of the cells of the renal tubules, and things that can cause that. Think about nephrotoxic drugs, your vancomycin, your aminoglycosides, your NSAIDs even, all right? Rhabdomyolysis, where there's severe muscle damage and myoglobin is filtered through those renal tubules, causing damage and necrosis to those tubule cells. Hemolysis, so a massive hemolytic transfusion reaction, where those broken down blood cells are kind of filtered through the tubules and cause damage to those tubule cells. Malignancies like multiple myeloma can cause acute tubular necrosis. Acute interstitial nephritis is not classified as acute tubular necrosis, but it is another cause of intrarenal acute kidney injury. So things that can cause acute interstitial nephritis are things that cause inflammatory fluid, interstitial fluid that is in between those tubules. So there's fluid naturally in between the tubules, within the Bowman's capsule. And so any process that causes, an inflammatory reaction there can cause acute interstitial nephritis. So think about drugs like proton pump inhibitors, like our Protonics that we give everybody for GI prophylaxis, right? Think about those beta-lactam antibiotics. Also, things like lupus can cause acute interstitial nephritis, all right? And then finally, glomerulonephritis, which is an inflammatory response of the glomeruli itself, typically follows a strep throat infection. And so glomerulonephritis can actually lead to intrarenal AKI. Finally, we have post-renal causes, which is probably the easiest to remember. So post-renal causes are when there's something going on that prevents outflow of urine, okay? So think about like BPH or prostate cancer, which blocks outflow of urine through the urethra. Think about your Foley catheter. If it's kinked somehow, even on the inside of the patient, or it's obstructed somehow and just needs irrigating, that blocks outflow of urine. Renal calculi or kidney stones. Neurogenic bladder, where urine is just sitting in the bladder And I think about, you know, those anticholinergic drugs that, remember an old saying where my nursing professor said that anticholinergics make you where you can't see, you can't spit, you can't pee, and you can't. So neurogenic bladder can, be caused by anticholinergic drugs. So anything that prevents outflow of urine, prevents it from getting out of the body, can be a post-renal cause of AKI. All right, so before we move on to the other side of my board, we're going to talk about, two of the main processes of the kidneys, right? Of that functional unit, the nephron. So we have filtration and we have reabsorption. All right, so filtration is basically where we're filtering things out of the blood, water, solutes, glucose, ions like your electrolytes and stuff like that. And then reabsorption happens in those tubules, in the proximal tubule and the distal tubule. And that's where, we reabsorb substances to maintain serum osmolality and things like that. So all these processes are working together to maintain serum osmolality, to maintain excretion of waste properly, because it's kind of like lots of things get filtered out, but not everything that's filtered out is actually secreted out in the form of urine, right? We actually have to reabsorb some of those things to maintain a good balance, maintain acid-base balance, maintain a good electrolyte level, just maintain overall, homeostasis within the body, all right? So I'm gonna flip my board around here. And we're just gonna start off by talking about, a normal urine output is anywhere from 1 to 2 liters per day. So that's 1,000 milliliters to 2,000 milliliters of urine per day. All right, so anything greater than 2 liters of urine output per day is considered polyuric. And these are actually 2 stages of acute kidney injury. There are 3 stages. The initiation stage, which is honestly not really worth mentioning because there's not going to be any signs and symptoms there. Next is the oliguric phase. This is where you're going to see the vast majority of the clinical manifestations associated with AKI. All right, so oliguric means low urine output. The number to remember there is 400 milliliters of urine in a 24-hour period. That constitutes the oliguric phase, all right? That is gonna last a week or 2, and then if your patient moves into the polyuric phase, then obviously they're gonna be putting out more urine than 2 liters per day, all right? But the number to remember here for oliguria is 400 milliliters per day, less than that, all right? So let's think about signs and symptoms, what we're going to see. All right, so the signs and symptoms, the manifestations, the potential complications, I'm going to focus on that oliguric stage where the patient is really not putting out much urine. All right, so in that oliguric stage, we have very low urine output. We have BUN and creatinine that are continuing to rise every single day. A normal BUN ranges from 10 to 20, give or take. Make sure you follow your professor's guidelines. A normal creatinine ranges from 0.6 to 1.2. So in the oliguric phase, both of these are increasing daily. A third lab that we like to look at, and this is honestly our primo lab that tells us exactly how well the kidney is functioning, is the glomerular filtration rate. Remember those 2 processes? Filtration and reabsorption. Well, our glomerular filtration rate tells us the rate at which our kidneys are filtering. We want that number to be about 90. When it drops below 60, we know that our patient is really in trouble. All right, so let's talk about the oliguric stage and what we're going to see. So we're going to see general signs and symptoms, just the conglomeration of manifestations that we see in this stage is all kind of referred to as uremia or azotemia. And this is going to be all the manifestations of the electrolyte levels that are out of balance, the acid-base, imbalances that we're going to see, the fluid volume overload that our patient is experiencing. And so uremia is going to consist of high urea levels also. So the buildup of those waste levels, the buildup of urea within the system, within the blood circulation, causes things like fatigue, nausea and vomiting, confusion, mental status changes. You might notice that your patient is reporting a lot of itching, okay, and that's the uremic frost that you might kind of see on the skin. And so you've got to protect your patient's skin from itching and scratching. All right, so as far as labs, what will we see? Well, BUN and creatinine, I go back to those because those seem to be harped on the most as like the most important labs that we look at when our patient is in acute kidney injury. Honestly, GFR is where it's at, but let's talk about BUN and creatinine. BUN is how the blood reflects the level of urea that is in the blood. Urea is a byproduct of protein breakdown within the blood, okay? So as BUN goes up, that means the urea level within the blood is going up. Creatinine is the byproduct of muscle breakdown within the blood. So creatinine is typically going to remain constant as long as your muscle mass remains constant and you don't start, embarking on a bodybuilding, journey or whatever. Creatinine typically stays constant, whereas BUN can fluctuate very easily with, dehydration, with your protein intake. So out of these two, out of BUN versus creatinine is going to be a better reflection of renal function than is BUN. Now, going back to urea and creatinine, urea is actually one of those things that is reabsorbed. Remember when we talked about filtration and reabsorption and how we filter stuff out? We filter a whole bunch of stuff out, but then the tubules go, whoa, we need some of this stuff back into the blood to maintain a state of homeostasis. Urea is one of those things that is reabsorbed within the tubules, okay, to help maintain concentration of urine, to help maintain osmolality and things like that. And so urea is reabsorbed, whereas creatinine is not reabsorbed in those tubules, okay? So again, that's why our BUN level can fluctuate, because if, our, tubules are deciding to reabsorb more urea because of a state of dehydration or, what have you, then that BUN level is going to fluctuate very easily. All right, so what are the other, manifestations aside from, what I've talked about as far as uremia, what I've talked about as far as lab values? Well, when we think about oliguria, we're going to think about all things fluid volume overload, right? So we're going to think about edema, the most dangerous type being pulmonary edema. So we're going to listen to those breath sounds. We're going to monitor respiratory rate and effort. We're going to monitor ABGs for other reasons as well. We'll talk about that. We're going to monitor that O2 saturation, and we're going to give patients oxygen as necessary, right? Always ABCs, okay? We're going to place these patients on fluid restrictions if they're on, in that oliguric stage, and they absolutely hate this, y'all. I can only imagine, because 1 can of Coke is 360 milliliters, and typically these patients are on anywhere from 1,000 to 1,500 milliliter fluid restrictions per day. You're going to implement safety, precautions because of the, the possible confusion, the possible mental status changes. Obviously, I's and O's are going to be extremely important. daily weights, because we're monitoring for weight gain and more fluid retention. We're going to look at electrolyte levels, all right? So in the oliguric phase, what will we see as far as electrolytes? Well, in any state of fluid volume overload, you will see a low sodium level, correct? So, a dilutional hyponatremia. So sodium will be low. Potassium is going to lean towards being elevated. And the reasons for that are kind of multifaceted with acute kidney injury, because there's lots of things going on that cause an elevation in potassium. But one of the things that the kidneys, one of their jobs is to produce bicarbonate and also filter out excess hydrogen ions and secrete hydrogen ions. Well, the kidneys that are failing, that are in the oliguric stage, are not able to produce bicarbonate, and they're not able to filter out and secrete hydrogen ions as they are supposed to. So we're going to be looking at a state of metabolic acidosis in these patients, so a very low pH level. And anytime we have a metabolic acidosis or an acidosis, we're always going to think hyperkalemia, elevated potassium levels, okay? So the kidneys also are, pretty much unable to filter out and secrete potassium. So potassium is going to go up, up, up. So what do you think about as far as what's going to kill your patient with hyperkalemia? Dysrhythmias, okay? Get that patient on the monitor. Monitor 12 lead EKGs on these patients. You're going to look for PVCs. Telltale sign of hyperkalemia is very tall, peaked T waves, possibly a prolonged PR interval, a very wide QRS complex. All of these may be seen in patients with hyperkalemia, and hyperkalemia is very, very, very common with our renal patients. Phosphorus. Phosphorus is another electrolyte that the kidneys are not going to be able to filter and secrete as they should. So think back to fluid and electrolyte lectures. I know you don't want to think about that, but remember how phosphorus and calcium have an inverse relationship. So if phosphorus is elevated, as it will be in acute kidney injury, then your calcium is going to be very low, all right? And so the manifestations that you'll see that accompany hyperphosphatemia are going to mimic hypocalcemia. So you'll have a high phosphorus, a low calcium, and signs and symptoms of low calcium. And remember that calcium calms. So with a low calcium, everything's going to be hyperexcitable. So laryngospasms are going to be the most dangerous manifestation of hypocalcemia, but also things like tetany, a positive Chvostek sign, a positive Trousseau sign. You're also going to think cardiac, okay? You can have cardiac dysrhythmias with hypocalcemia. So you want to be sure and monitor for that. Cardiac is always going to be affected when you have someone with severe, significant acute kidney injury, okay? So we've talked about the pulmonary aspect, we've talked about electrolytes, we've talked about the cardiac aspect. Let's talk about, acid-base imbalance, because that's one of the jobs of the kidneys as well, right? We're supposed to maintain acid-base balance by producing bicarbonate and eliminating hydrogen ions. Well, again, that's not going to be happening. So we're going to be looking at a metabolic acidosis where our pH is very, very low and our bicarbonate is very, very low. Okay, so a metabolic acidosis. We're going to monitor daily ABGs for that, possibly give bicarbonate, to correct that, sodium bicarb to correct low bicarb levels. As far as treating elevated potassium, because elevated potassium is, presents such a risk for cardiac dysrhythmias, That's got to be the first thing on your mind. So the treatment for that is going to consist of calcium gluconate, IV insulin, and Kayexalate. Which one of these do you think we would give first? We're going to give calcium gluconate first, because calcium gluconate, in essence, protects your heart from dysrhythmias, okay? So we give that calcium gluconate to go ahead and protect the heart from the potential dysrhythmias of a really high potassium level. Then we're going to give things like IV insulin that pushes potassium back into the cells. We're also going to give dextrose to make sure that we don't bottom their blood glucose out, okay? And then Kayexalate, which eliminates potassium through the stool, okay? So that's the treatment for elevated potassium levels and, you know, prevention and treatment of dysrhythmias. Diet, so these questions always come up, you know, on exams. So low potassium foods, low phosphorus foods, obviously, low sodium, low protein, because, you know, of elevated urea levels, low phosphorus, I think I may have said that, low potassium. So, you know, we're going to get that banana off that patient's tray, the tomatoes, things like that. We're going to really, orange juice, we're going to make sure that we're monitoring for that. So make sure you know the importance of diet and nutrition, because those questions are very, very popular on nursing exams, guys. So that pretty well sums up, you know, acute kidney injury. We talked about pre-renal, intra-renal, post-renal causes and the different underlying etiologies. We've talked about the manifestations that we're going to see in that polyuric stage, and y'all, that is where the majority of your test questions are going to come from, is talking about that polyuric stage, that fluid volume overload stage, that metabolic acidosis, that hyperkalemic stage, and then we've talked about the priority nursing interventions, okay, as far as thinking about airway, as far as thinking about cardiac dysrhythmias, and acid-base balance, and just making sure that, you know, we're doing everything we can to prevent further complications for our patients. So I hope you guys have found this video helpful. I know we've talked about a whole lot of stuff in a short amount of time, but I hope your semester is going well, and I just thank you guys so much for watching my video today.